Today I'm going to talk to you about the quantitative assessment of neuromotor development in children, which is a quite different topic with respect to the one I was working on when I was at the Laboratorio di Tecnologia Medica. As Egon mentioned this morning, I work with microCT under the supervision of Egon, Luca and Fabio for my final project during the bachelor degree. It was my very first research experience in a scientific lab, and when I look back and think at what I learned during that period, besides the obvious excellent technical and research competencies of all the people I met there, I think it is the love and the passion for biomechanical research that comes out clearly from all the presentations we are seeing today. So I'm really grateful for the opportunity I had. Okay, now let's move to the presentation topic. So first of all, I want to describe the global problem around this research topic. During the very first year of infants, we all pay a lot of attention to their motor development, asking, for example, is the child able to work independently? But unfortunately, after this first period, attention on motor development declines. Despite this, we know now that there is a global overall decline in motor competence. Children are not achieving motor skills as they did in the past decades and as they are expected to do. The problem is that there are precise windows where some motor skills have to be developed. The second issue is a quite high incidence of minor motor delays in the childhood population that are often not timely diagnosed, leading to ineffective intervention. Both motor delays and motor disorders are demonstrated to have several long-term consequences, for example, on physical function, academic achievement, mental issues, a risk of obesity, and we have to think that nowadays children will be the adults and the elderly of tomorrow. So my focus here is to use the biomechanical approach to understand and study motor development, with the aim of identifying early biomarkers of motor impairment or delay, supporting a quantitative overall monitoring of motor development and the design of interventions. However, when we deal with the quantitative assessment of motor development, we have to know that it is a discontinuous process, intrinsically variable, and occurring within a self-organizing system. So the characteristics to be quantified will depend on which age and which task we are looking at. When looking at locomotor performance from a biomechanical point of view, different factors can be considered the guiding principles governing the dynamics of locomotion, such as metabolic expenditure, stabilization, mechanics of proportion, and so on. However, depending on the specific challenge and goal of the motor task, different factors are expected to be prioritized. What we know from quantitative studies on child motor development is that with maturation, there is an increase in agility and ability to make complex movements. On the other hand, if we consider daily living tasks such as walking, there is also an increase in automaticity of performance. In this perspective, we have to choose some locomotor tasks that are able to highlight this kind of characteristics. So natural walking and tandem walking are two locomotor tasks that both require a controlled progression of the center of mass, but are characterized by different constraints. Natural walking can be considered the gold standard locomotor task for locomotor assessment. It is a daily living task, and it can highlight the increase in automaticity with experience and age maturation. Tandem walking is a locomotion pattern where the toes of the back foot touches the heel of the front foot. Thus, it challenges the postural control system more than natural walking, and its successful execution requires the maintenance of stability, including the ability to ambulate with a narrow basis of support and to have accurate balance and leg control. Thus, tandem walking may be used as a task to highlight aspects related to the flexibility of the system. But what instruments can we use to assess and quantify children's motor performance during these tasks? Wearable inertial sensors have been proved to be useful to similar purposes in pathological population in the literature, and using them we can measure 3D acceleration and angular velocities of body segments with the many advantages we know, as they can be used outside of the laboratory, they are low cost, unobtrusive, and simple to use. With these instruments, we can follow a classic human movement analysis approach and measure parameters that are related to the peripheral realization of movement pattern. An easy example is the quantification of gait temporal parameters, such as stance, double support, and their variability. In this case, the positioning of sensors on the lower legs allows an accurate and reliable quantification of these parameters in children. There are also other approaches that use nonlinear measures for quantifying human movement performance, aiming at characterizing different aspects specific of the motor control underlying the realization of that movement pattern. Typically, they are applied on kinematics of the trunk, under the hypothesis that the control of the center of mass is a leading factor in the control of progression. I want to show you an example that I find always clarifying. Here we have two infants who sit independently. Let's think that the signals we are seeing are trunk acceleration on the anteroposterior direction. If we just compare linear measures as mean and standard, the two signals are comparable. However, I think that you all agree that they are not. The predictability and the complexity different. The child on the top figure is showing a lower level of complexity, with postural adjustments that are only direction specific. The infant on the bottom figure is more mature and is already showing anticipatory postural activity, which is reflected in the complexity of the signal. So going back to our selected locomotor task, we can look here at the performance of tandem walking of two kids, a 5-year-old child on the left and an 8-year-old child on the right. They both can perform the task, as they do not make standard clinical errors, that is, for example, leaving empty space between the feet. However, if we focus on the control of the trunk during the execution, we can see the difference between them. Here you can see exemplificatory trunk acceleration signals during the two tasks for a 6-year-old child, a 9-year-old child, and a young adult. As you can see, in tandem walking, the complexity of the signals increases and the predictability decreases with age maturation, and the opposite happens in natural walking. So having preliminarily shown and verified what novel nonlinear metrics can, what kind of information can provide for characterizing motor control performance during these two tasks, we propose a cluster of parameters that can be extracted from inertial sensors. With this kind of parameters, we aim at assessing both different specific aspects of motor control related, for example, to complexity, regularity, but also to provide standard information about the quantitative description of temporal parameters of the tasks and their variability, such as stance duration and double support. Given the numerous indexes we are measuring and the need of a synthetic visualization of the different aspects, we propose a visual polar representation. So here is just an example where you can see the different sectors representing different aspects of motor performance. So in this particular study, we've considered a wide age range and included participants from 6 to 25 years old. Collecting data with 3 inertial sensors, 1 on the trunk and 2 on the legs during the two tasks, natural walking and tandem walking, and that we calculated the previously mentioned parameters. With this approach, it was possible to highlight the effect of age maturation, as you can see here. So here we have age reference bands obtained, median and interquartile values for natural and tandem walking. As example, if you look at the upper left sector, you can see that in both tasks, variability of executions decrease. So from left to the right, you can see that the variability goes. If you look at the lower left sector, you can see that entropy measures describing motor complexity decreases with age in natural working and increases in tandem working. Ideally, these bands could be used as a reference, allowing to compare a single child performance and see if their polar plot is representative of their age. So in order to verify this possibility, we wanted to test this approach also on a population with a small age range to see if we could discern between levels of motor competence. In particular, we focused on school children aged 6 or 7, and we analyzed the results of the polar plots following the same experimental protocol with respect to age, sex, motor competence, and suspect of developmental coordination disorder. That is a minor motor disorder with an incidence of 5% in the population of children. Motor competence was assessed using a standard product measures, the test of motor competence, that simply counts the time of execution of a list of motor tasks. So the more competent the child is. And then we asked to parents to fill out the DCD questionnaire, which is a standard questionnaire for highlighting suspects of developmental coordination disorder. So when analyzing results with respect to age, despite the small age range considered, we obtained trends that are in agreement to those shown in previous works. With respect to sex, we did not find any significant difference between males and females. Here, you can see results analyzed with respect to motor competence. In the first column here, you can see the children in the lower quartile according to the test of motor competence results, and in the second column, children in the upper quartile. As you can see in the bottom, the age range was really similar in the two groups. Now, if we compare these results with the age reference bands I showed you earlier, you can see that less competent children showed a motor performance comparable to that of younger ones, and vice versa, more competent children to that of older ones. Based on the results of the DCD questionnaire, we found 5 children with suspect of DCD. Here you can see the polar lines of each child plotted with respect to the age-matched reference population. The analysis of the singular curves allows understanding in which area the child shows a possible motor delay, understanding which components of motor control are mostly affected, and supporting the definition of effective focused interventions. Ideally, as an example, if a child shows a complexity during tandem working lower than expected, they should be encouraged to explore different movement strategies in order to enrich their ability to adapt and develop effective motor solutions. On the other hand, if the variability during, for example, natural working is too high, training with task repetition should be encouraged in order to improve automaticity. So the proposed quantitative assessment resulted suitable for characterizing locomotor development in children and highlight potential risk of motor delays. In the future, we would like clearly to apply it on larger group of children, possibly on longitudinal studies, and also to focus on specific population at risk of motor delays, such as preterm children. Last but not least, to make a connection with this field of research and other topics that are being presented today, this kind of motor performance quantification could also support in silico analysis of human movement when integrated in musculoskeletal models, for example, allowing taking into account specific alterations of motor control. So thank you very much for your attention, and if you have any question, I will be happy to answer during the coffee break.
Okay. Thank you, Maria Cristina. Thank you, and compliments for your nice presentation. I will give the word to the next talk is about on the biomechanical approach to stability, posture, and breathing by Simone Tassani. Simone?
Here I am.
Okay.
Now let me share my desktop. No.
Okay, thank you.
Okay, can you see it? Can you see the presentation?
Yes.
I think, okay, very good. So thank you very much, everybody. Well, talking after Christina is a bit embarrassing because she has deep knowledge of posture and walking, while I just moved to this field of study in the last 2 years. Actually, when I was at LTM, I spent a lot of time working mainly in medical imaging and bone mechanics. It was my original field of study. And I spent quite a time at LTM, time enough to defend 4 different theses. I have here a contribution picture with my with my supervisor, with Egon and Fabio, when my hair were differently distributed in the head. So at the beginning of my career, I was working mainly, as I said, in bone mechanics, together with a group of Max Massimiliano Baleani, with experimental guys that were breaking bones and testing the samples of trabecular specimen. And in the other room, we were taking micro-CT images of this specimen before and after fracture to characterize its behavior. This specific slide, I think, is 15 years old, coming from my master dissertation. So I spent quite a time working in this field. My PhD was based on this. When I left Bologna and I moved to Athens with Marie Curie action, I kept studying the fracture of a trabecular bone using image processing and data classification, data analysis, were the tools I studied when I was in Athens. And so what link, how did I move from tissue level to body level? What is the link between the relationship between trabecular bone and biomechanics of the body? Well, there can be several links. One was explained actually this morning by Egon, but this is not the path I used. Actually, I must say that what I did was, after my Marie Curie, I moved for 3 months to China, studying Tai Chi, and this was so interesting to me that I decided this must be part of my work. So I wanted to move this discipline inside my study. And so what I tried to do, start to see how this discipline is actually used in research. There are several papers published. In the last decade, the papers that are studying Tai Chi are increased exponentially. But what is Tai Chi? So Tai Chi is an ancient martial art based on stability and elasticity. Training is typical for this internal martial art and is done doing repetition of slow movement that are flowing softly from one position to another, and these movements are called forms. There are a lot of breathing and meditative aspects included in the discipline. So for all these reasons, this discipline is suggested as physical activity for well-being for other people. So there are many studies that are trying to apply Tai Chi to problems related to stress, cardiocirculatory disorder, even tumors, and of course, musculoskeletal disorders. The problem for me as an engineer was, what should I measure? It's easy to say, let's train someone in Tai Chi and see the effect. But there are several sources of variability. First of all, the discipline itself is divided in in 5 actually 5 different main ways of teaching, and each has different forms for a total of hundreds of different ways of teaching the same discipline. So this is one form of one source of variability. Another form of variability is, are we sure that the people is actually learning Tai Chi? Because many studies, of course, have to fight with time. So you ask people to learn something in 2 months, and then you take measures again. Are these months enough to learn Tai Chi? So from my point of view, the main issue was, what should I measure? Where should I start from? And if you dig a bit into the discipline, you understand that all the different approaches to the same to Tai Chi have one main method, which is relaxation. So if you are not able to relax while you're performing your Tai Chi form, means you did not really learn Tai Chi. And so we can say that Tai Chi improves stability, perception, speed, and stamina, teaching how to relax. And here it's interesting, the cultural barrier. Now, what is relaxation? In Chinese, they say feng song or simply song. If you say someone song, they understand perfectly what they have to do and they start to relax. If you talk about relaxation in Europe, many people talk about something like this. This is not what we are talking about. Okay, this we can call it rest. It is important, it is a fundamental part of life, we have to rest, but we are talking about relaxing under stress. So during the stress task, you must learn how to relax. To explain a bit better this situation, I use an image from a paper of Martelli, Saulo, 2011, where he was showing different possible heat loads due to suboptimal neuromotor control. So when we rest, we are outside of the graph, of course. The load is low, clearly, but we are not fulfilling the task. The idea of this kind of disciplines is to try to move in the point the loads are minimal that you require to solve the task. On the other side, of course, you can put tension, you can put a lot of strength. You will still succeed in performing your task, but you will place a lot of tension there. So this was actually what I wanted to study. So I moved to Barcelona with the idea to study the effect of muscular tension over stability. So in my mind, this was very far from the idea of studying Tai Chi, but I needed to start from a point, to have some fixed point to say, okay, this might be the route from where I could start. So what we did, we tried to develop a very easy experiment. We asked 30 subjects to stand over a force plate, and we monitored the displacement of the center of pressure. We measured 16 different time and frequency domain parameters to verify if their stability was varying and how it was varying. We asked them to perform the task in 3 different states. One control state in which we were just asking the subject to enter in the lab, watch the wall, and stand so over the force plate. Another intention, where we asked the same subject to raise the shoulder, contract the gluteus, and this was simulating a situation of tension. We selected this muscle because I think if you are familiar with this kind of problem, it's easy to find people with have tension in the shoulders, tension in the back, pretty natural situation of tension, even in tasks as common as standing. And then we perform a 3rd repetition in relaxation mode. So in this case, we asked the subject to perform a brief some exercise to relax the shoulder, to relax the head, to relax the hips. And we asked the subject to breathe with the diaphragm, to have deep diaphragmatic breathing. Why it is important is because actually having diaphragmatic breathing, first of all, change the volumes a bit of breathing, but also performs a continuous massage over the pelvic floor. And this helps relaxing the hips and improving stability. So we ran a test and we've seen how tension was actually reducing stability in all the parameters that we were measuring. So here there was there were no doubts in this case. Someone else talking? No? Okay. The comparison between relaxation and control was not as clear. So there were some parameters that were suggesting more relaxation, but there were others that were suggesting less stability. So some parameters were suggesting more stability, some others were suggesting less. And here we had some doubt because what we found was that only a small percentage of the volunteers were really able to breathe with the abdomen. The most of them had some doubts or were not able at all. to breathe with the diaphragm, and that was a bit of an issue because this is supposed to be the main key for relaxation. So we were not really sure anymore about what we were measuring. So we understood we had to do another step back and going even more to the root and say, okay, we have to look at breathing. We have to look how these subjects are breathing. How can we do it? We choose optoelectronic plethysmography. So we used the 89 markers placed on the chest of the volunteers to verify which compartment was actually used while they were breathing. If it was the pulmonary rib cage, the abdominal rib cage, or the abdomen. So we had 10 volunteers. This time we placed the markers over the chest, and we asked again to repeat the same analysis with this three-state control, tension, and relaxation. This time we monitored them for 3 minutes, and we had some interesting results. First of all, of course, the difference in volume and frequency of breathing were statistically different. This was sort of given because during long, deep breathing, it is normal to have higher volume and to have less frequency of breathing. But there were still differences also in breathing between control and tension. What we did not see was difference between the compartments, which was supposed to be there, because we asked subjects to breathe with the abdomen during the relaxation. We did not see typically this variation. If we look at the stability, again, we confirmed that tension reduced stability, but, and again, we confirmed that relaxation was a bit unclear. So we went back looking at breathing, trying to understand what was happening, why there was not this, there was no variation. And we have seen that actually of the 10 subjects, only 3 were really able to breathe with the abdomen, with the compartment of the abdomen. Most of them were making no differences, and some of them were actually, when asked to breathe with the abdomen, were actually breathing more with the pulmonary rib cage. So splitting the volunteers in this way, so dividing who is able to breathe with the abdomen and who is not, we start to make some sense on the result. Of course, here we cannot talk statistics anymore because we have 3 against 7. But we start to see how people able to breathe with abdomen actually seems to be more stable than the one that is not. Still, we have some uncertainty that we don't see much difference between the normal stance and the relaxed stance. But we start to see something, okay? So based on this, we started recently a new project, which is called Breathing Dynamic Modeling for Body-Mind Interaction in Students, with the acronym BIMBO, which, by the way, in Italian means little kid, and was, of course, inspired to my little son, he's 1 year old, close the parentheses. So in this project, what we aim is to study 60 students, so healthy and around 25 years old, trying to find this triangular relation between breathing, stress, and posture. Stress, both actually physical and psychological, because there are several references that indicate how psychological stress can induce musculoskeletal disorder. Why dynamic modeling? Because actually looking, as Maria Cristina was showing before, looking at averages and standardization sometimes is not enough. And you can see how different subjects can have similar averages, but with quite different signals along time. It is interesting to notice how the people that the subject here, the high one, that was able to breathe with the abdomen compared with the one that was breathing prevalently with the pulmonary rib cage. Of course, they changed the compartment, but you can see how in one case the standard deviation is much smaller. The breathing cycle is much more repeatable in one situation compared to the other, and this is going to affect the posture and the variation of the posture. So before to close, this is my group at the moment at UPF in Barcelona, Universitat Pompeu Fabra. But I don't forget my origins, the original group, and actually I'm still having some collaboration with Martino Pani, which now is working together with Gianluca Tosti in UK, and also with Egon Perilli. We are having a research topic on frontiers that will close in February. So if you want to publish something, just contact me. Thank you again.
Thank you, Simone, for this interesting Tai Chi discovering. So I would like to introduce Francesca Bottin for the next talk, and she will speak about the simulation maximal isometric leg extension. Francesca?
Good afternoon to everyone. Now I try to share my presentation. Can you hear me? Yeah?
Yes.
Okay.
Full screen.
Okay.
Okay,
so,
thank you.
Thank you, Saverio. Good afternoon, everyone. My name is Francesca Bottin, and I am a PhD student at the University of Bologna. All the speakers before me have spoken about their personal and professional stories. I'm at the start of mine, so I have no interesting memories to share. However, I just started my PhD less than a month ago at the Medical Technology Lab, but I started in this lab 1 year ago, working on my master thesis. Oops. Okay. I hope my first presentation, would have been in person and not through a computer. However, let's start talking about maximum isometric leg extension. Maximum voluntary isometric contraction task, or MVIC task, is a standardized method to measure and evaluate muscle strength. During these tests, subjects are in a sitting position, and they are asked to perform a specific task, in this case a leg extension. So people exert their maximal quadriceps muscle contraction while the limb of interest is strapped to a fixed arm to ensure isometric condition. So throughout the execution of the test, muscle fiber lengths do not change. The net force, or the net moment produced by quadriceps muscle, is measured by a load cell embedded in a dynamometer just positioned above the ankle joint, like shown in the picture, or handheld by an operator. So the assessment of the strength of skeletal muscle is fundamental for many reasons. MVIC test allows to quantify the loss of muscle strength, which is an important predictor of the risk of fall in elderly. It's also important to the diagnosis and the treatment of those patients with neuromuscular disorders. It provides information on the clinical course of disease and assists in evaluating the efficacy of pharmacological or other therapeutic interventions. Moreover, athletes often use MVIC tests during their training to strengthen their muscles in order to achieve a better performance or assist in recovery from injury. These tests are quite simple to conduct in principle, but they are prone to inaccuracies. First, they rely on the expertise and strength of the examiner, and second, they rely on the intensity of stimulus. For example, verbal stimulus examiners give to participants throughout the execution of the test. So, muscle skeletal modeling techniques and biomechanical computer simulations may help to standardize these testing procedures, thus reducing human errors and increasing retest repeatability. Over the years, in silico methods have been used to simulate maximum voluntary contraction tasks. Mostly, simulations are informed by motion capture data And due to the lack of information about the human-seat interaction, to ensure dynamic consistency throughout the simulation, the overall body motion is constrained, usually by fixing pelvis position. And here we can see this is a common practice and a common approach while simulating cycling tasks. However, what if the motion capture data are not available, and why useful to reduce the complexity of the problem? How much do these simplifications influence the outcome measure? To answer to this question, we developed a simulation framework to conduct MVIC tests in silico, implementing two different sets of boundary conditions. OpenSim was the software used throughout the entire simulation, and we used Gate 2392, which is the most widely used generic model provided again by OpenSim. This is the workflow we proposed. It consists of three different parts. First, we defined the human-seat interaction, and as I said before, two different sets of boundary conditions were implemented, one more simplistic and one more realistic, but I'll go more in detail in the next few slides. Second, we ran static optimization tool, which provides muscle forces by minimizing the sum of square muscle activations. We imposed different kinematics depending on the approach, simplistic and more realistic, and we imposed the knee flexion torque that was increased by 1 Newton per meter steps of 1 Newton per meter at each iteration. So the last torque value that muscles were able to sustain and generate was considered to be the MVIC torque. And third, we compared the estimated outcome to maximum contraction torque and muscle activation. Our working hypothesis was that modeling human-seat interaction will substantially affect the predictive accuracy of a computer simulation of the MVIC test. As I said before, two different settings of boundary conditions were implemented and tested. In both cases, the model was fitted with hip and knee joint flex of about 90 degrees and the back slightly tilted. So this is a common set used during an MVIC test, so described also in literature. In the simplistic approach, in line with previous works, all pelvic translations were fixed, and this initial pulse was kept constant throughout the simulation. On the other hand, in the realistic approach, pelvis was free to move, and contact elements and spring damper elements were introduced to limit, in a sense, the motion of the model. 6 unprotected forces, 3 were defined to simulate the human-seat interaction, and those forces are characterized by parameters chosen based on values reported in literature. On the contrary, for simulating seat belts, we define 2 spring damper elements, defined respectively in the superior-inferior direction and in anterior-posterior direction. Of course, 2 spring damper elements on each side. The kinematics used as input of static optimization was obtained from a forward dynamic simulation of 4 seconds, where tibia body was completely constrained to the ground and quadriceps muscles were maximally activated. So, in terms of maximal isometric knee extension torque, MVIC torque equal to 161 Newton per meter was observed when the pelvic position was fixed, so in the simplistic approach where pelvis was not allowed to move. On the other hand, on the contrary, modeling the human-seat interaction resulted in a lower MVIC torque equal to 145 Newton per meter. However, independently on the applied boundary conditions, the model was able to sustain an external flexion torque in line with values reported in literature for an age-matched healthy adult population. The area in gray represents those experimental data reported in literature with an average of approximately 144 Newton per meter. In both cases, so in the simplistic approach and in the realistic approach, the quadriceps muscles were maximally activated. So for these four muscles, activation was equal to 1. And however, some muscles exhibited different behavior depending on the applied boundary conditions. In the simplistic approach, activations of hip abductor and hip extensor muscles were lower than in the realistic approach. As I said before, in both cases, the estimated MVIC, knee extension torque, was within the range of experimental literature data. The inclusion of contact elements and the presence of seatbelts resulted in MVIC torque closer to the one reported in the literature for an age-matched population. However, differences between
you are doing prior art.
Someone is talking? Someone else? No? Do you hear me? Yeah.
Yeah, it's okay. Carry on.
Okay, sorry. So as I said, modeling more realistic boundary conditions resulted in a MVIC torque closer to the reported average value for an age-matched population. However, differences between estimated outcomes and literature data were within 12% margin of error, and based on these results, we cannot conclude if this difference is due to the applied boundary conditions or the uncertainty inside the model itself, so a model which is a generic model. In addition, it has to be considered that implementing more realistic boundary conditions require much more time, and it has a higher computational cost when compared with the simplistic approach. And the identification of parameters chosen for characterizing contact elements is affected by uncertainty. Moreover, a possible reason behind the difference between the activation of some muscles is the general imbalance due to the external forces acting on the models. Those forces were zero-edge when the pelvis was not allowed to move and translate, but they may have triggered activation of which are not directly involved in the knee extension task and expand the hip joint. So this was an exploratory study and had few limitations. First, while implementing realistic boundary conditions, the model was not informed by nor validated with experimental data. And in future available experimental data, such as from the Migrant Challenge competition or experimental data acquired in laboratory, may be used to validate the proposed workflow. And second, all parameters we used to characterize the contact elements and the spring damper elements were based on previous work. So a sensitivity analysis is required to get a better understanding of the effect that such parameters have on the outcome measures. And that's all. Thank you for your attention. If you have, of course, any questions, drop a message at my table and I will be glad to answer them. So,
thank you, Francesca, for your nice presentation. last but not least, Giorgio Davico, development of personalized models for children with cerebral palsy. Giorgio, when you want.
Yeah. Okay, just share my screen.
I see you, okay.
Okay, so I'll just put it full screen. Can you see it properly?
Yes, sir. Perfect.
Okay, so thank you everyone. Thank you Saverio for the introduction, and good afternoon everyone. As Francesca, I won't have any historical background slides because literally as her, I started a little over a year ago here in Bologna. And this is also the reason why today I'm going to talk to you about the last study I conducted during my PhD back in Australia at Griffith University on the development of personalized models for children with cerebral palsy. To set the context, cerebral palsy, often referred to as CP, is the most common motor disorder in childhood. Every year, nearly 2 in 1,000 newborns are diagnosed with CP, and it is estimated that worldwide over 17 million people are suffering from this disease. Now, CP is a very complex neuromuscular condition that originates from a non-progressive lesion or damage to the brain or the spinal cortex that normally occurs before or at birth. This is triggering altered muscle activation patterns that are responsible for structural and morphological changes to the muscular tissues, as well as for the generation of aberrant muscle forces. These in turn lead to the deformations of bones and joints as the body is still under development, and ultimately to gait deviations. What is, however, most important about CP is that once the body has been affected, despite the originating lesion is non-progressive, the body enters a vicious loop of adverse events that eventually lead to the progressive loss of motor function. And currently there's no cure for CP. However, the surgical and non-surgical intervention aim to restore typical gait patterns. And over the years, in order to assist clinical decision-making, musculoskeletal models have been increasingly used. And this is because musculoskeletal models are actually a virtual representation of the human body and its structure, where bones are typically represented as rigid bodies interconnected by more or less idealized and actuated by muscles. And when such models are combined with experimental data such as motion capture data or ground reaction force data, actually they make it possible to estimate internal biomechanical quantities of interest that can be used to drive surgery, such as muscle forces and joint contact forces, which cannot be measured otherwise in vivo, if not through very invasive instrumented implants. However, we need to be wary of the fact that when we use models, commonly employed musculoskeletal models are based on generic musculoskeletal anatomies that get linearly scaled to each subject size and dimensions through motion capture data, for example. But we know from literature that, for example, muscle tendon unit parameters do not linearly scale together with bones. Moreover, here we are talking about patients with CP, and we've seen that there are several deformities at the bones, at the joints levels, as well as we do have muscular changes at the structures, as well as morphological changes that these generic scaled models simply cannot capture. So when it comes to CP, we really need to go and define personalized models if we want to deliver effective and personalized treatment. And how do we go about this? Well, we can start from those generic scale models, but then we need to step up and increase the level of personalization within them. For example, we could calibrate and tune muscle tendon unit parameters to better describe how muscle works within a model. We could also choose different neural solutions from things such as an optimal control strategy to solve for muscle forces and muscle activations. And ultimately, we could also personalize the musculoskeletal anatomy, for example, using medical imaging data or statistical shape modeling techniques if we want to incorporate, for example, deformations. And this is what we've done in the study that I'm about to show you. Before going into the details, it's better we have a look at the workflow we use. It may be complex at the first glance. I'll try to break it down and simplify it for you. So first part is data collection. We had our participants come to the GATE lab. We placed markers on anatomical landmarks and surfaced EMG electrodes over the major muscles of the lower limb. We then asked the participants to perform simple locomotor tasks such as walking over a pathway where we had force plates embedded into the ground to measure ground reaction force simultaneously. And we then went to the magnetic resonance imaging clinic to collect MRIs of the full lower limb as well as dedicated knee joint scans. With all of this experimental data, we processed them and using different software applications, and we used them to develop and use and run biomechanical simulations, to develop musculoskeletal models and run biomechanical simulations within the OpenSim software. First, we estimated joint kinematics and joint kinetics, so angles and moments, and muscle tendon unit kinematics, in other words, muscle moment arms. And we fed these to the CNMS toolbox, where CNMS stands for Calibrated EMG-Informed Neuromusculoskeletal Modeling Toolbox, that allowed us to solve for muscle forces and joint contact forces using two different approaches for neural solutions. First, we did use a static optimization approach to hypothesizing optimal control, and did minimize the overall sum of squared activation. And then we used an EMG-assisted approach that used collected EMG data to inform, not to drive, our simulations. We did this for 6 children, and in our cohort we had 3 children with cerebral palsy and 3 age-matched typically developing peers. And we were lucky enough to have also a pair of identical twin sisters, one with TD and one TD among them. For each of these subjects, we developed several different musculoskeletal models. We started from a basic linearly scaled generic model that again featured linearly scaled generic musculoskeletal anatomies, muscle tendon unit parameters, and that was activated using or hypothesizing an optimal control strategy, so static optimization as I called it earlier. We then step by step increased the level of personalization, trying different combination of patient specificity, and we ended up ultimately developing what we call the fully personalized model that featured musculoskeletal anatomies based on MRI data, tuned and calibrated muscle tendon unit parameters, and muscle activation solved for using an EMG-assisted approach. We made overall 6 models per participant, and this is because we really wanted to understand which level of personalization was allowing us to estimate more physiologically plausible outcomes. And also, we wanted to understand and quantify the individual contribution of each level of personalization on the outcome measures. To address the first question, we initially assessed the ability of each model to track experimental joint moments and experimental muscle excitation. If we look now at the left-hand side of this slide, so over here, we see the results for ankle and knee joint moment tracking. We have 2 metrics, the coefficient of determination, R squared, that is an indicator of how similar 2 shapes or 2 profiles are, and the root mean square error, or RMSE, that is an indicator of how far apart or different the error basically between 2 curves. What we see is that all models that we developed perform very similarly to one another, and all very well, because the R square approached 1, which is the maximum, and the RMS error was relatively small. When we saw some differences was on the ability of the models to track muscle excitation. As expected, must be said, EMG-assisted models perform better or better track EMG data compared to the models that use an optimal control strategy. But we did not anticipate such low levels of R square for the first 4 models that you see in the picture. We then moved on and did a qualitative assessment of the total knee joint contact. And knew from literature data based on instrumented procedures that even during the swing phase of the case cycle, it is not physiological to see zero or close to zero loading. And nonetheless, some models do predict such low levels of loading. We put together all this information and we added also the knowledge on whether the anatomy was or not personalized, so based or not on medical imaging data, to define a scoring system in order to identify the most physiologically plausible model. Specifically, for each model and participant, we assigned 1 point every time one of the 4 criteria was met. Therefore, the overall score per model could have been 24, as we had 6 participants and 4 criteria. What we can see here is that the most personalized model was also the most physiological one, as it scored 23 out of 24, and it outperformed all of the other models. For this reason, we decided to use the estimate of this model as a reference for the next analysis. What we see here is what we did in order to quantify the individual effect of each level of personalization. So we see our results for mean muscle forces and total knee joint contact forces. This time, there are no longer 6 models per little graph, per subplot, because again, we were looking at incremental levels of specificity. So if we now look, we can compare the first and the second sets of bars, so the one underlined in red and blue, that only differ for the fact that the muscle tendinous parameters are calibrated and tuned or not. We can also compare the blue to the green, and in this case, we would compare and quantify the effect only of changing neural solutions, so from a static optimization approach to an EMG-assisted approach. And if we then look only at these bars underlined in green, this is already a direct comparison between what we call the calibrated EMG-assisted models that had generic musculoskeletal anatomies and our reference model, which was the most personalized. And these 2 models only differed for the musculoskeletal anatomy that was implemented. What we can see for both our outcome measures is that, supported also by the statistical analysis, is that calibrating muscle tendinous parameters seems to have little effect. On the other end, the neural solution significantly affected our outcome measures. And moreover, we also can see that there's quite a gap in both cases for the R-square, because they did not reach 1. This means that also updating and personalizing the musculoskeletal anatomy has somehow an effect. So we further dig into this problem, and we looked at the medial and lateral compartment loading. So what you see in here is a case example, which is actually representative of the overall results we found for the whole population on a typically developing child. On the left, we can appreciate the effect of changing neural solution. So on top, we have the results for the medial knee compartment. And we see that the 2 curves are actually fairly similar in shape and also in values, although the statistical parametric mapping shows some significant difference here and there. But when we look at the lateral knee compartment, that's where we start to see some major difference or deviation between the 2 curves. On the other end, if we look at the effect of the musculoskeletal anatomy, so we compare again calibrated EMG-assisted model and the most personalized model on the right, we see that now the major effect is on the medial compartment of the knee, as the 2 profiles still look fairly similar, but there's quite a gap between the 2 of about 0.5 to 1 times the body weight. Differently, on the lateral compartment this time, differences appear to be a little lower, despite sometimes again still significant. So what we can conclude out of this is that really personalization appears to be key, crucial to estimate physiologically plausible measures when we deal with pediatric populations and populations with neuromuscular disorders. However, we also have noticed that the neural solution seems to be affecting more joint contact loads on the lateral compartment, while the personalized anatomies do lead to reduced medial, and because of the magnitude, also the overall total knee joint contact load. Before closing, I'd like to acknowledge whoever made this possible. So my former supervisor team back in Australia, Professor David Lloyd, Dr. Christopher Curry, Dr. Claudio Pizzolato, and all of the other people that at different stages were involved in this study. And I would also like to thank you all. And if you have any questions or comments, I'm happy to take them later on during the coffee break.
Thank you, Giorgio, for this interesting presentation. Thank you all for your attention given to this section. And I would like to remember to you that any question, comments, what do you want, you can discuss with us during the coffee break time. Thank you again, and bye-bye.
Okay, we move to the next session, which is chaired by Luca Cristofolini. Luca, are you there?
Yes, hi, I'm here then. Good afternoon, everybody. So I'm happy to chair this session about computational bone biomechanics with 4 speakers. The first presentation will be by Enrico Schileo. I think I know Enrico from about 15 years. I guess it was 2005. We were having fun in the lab. We were making bets about the strength of the femurs that we were testing and that he was modeling. And the topic of his presentation is quite in line with this. His presentation is about bone strength and strain estimates from CT images. Enrico, the floor is yours.
Okay. No, I'm sorry, we had a problem with Enrico PC 2 days ago that could not be recovered, so I'm hosting his presentation on my account. So you will see my name, but it's him presenting. Oh, okay. So for that it was not possible to to adjust the PC by today.
It is very nice that you allow him to use your computer.
Okay.
So I hope I won't break also this one. Okay, so let me see if I can manage to launch my presentation.
Yep, we can see your slides.
Okay, I cannot see them, so.
We can, trust me.
Okay, so
let me see if, okay. Now I've also, so
if you can go to the presentation mode, it will be larger on the screen. Otherwise,
mine is in presentation mode.
Oh, then okay, you probably need to swap screens, but it's visible also this way. I guess it's okay.
Let me try again. Now?
Still looks the same.
Does it?
Miss animation.
Can you see now the screen?
We still
should be the first slide.
Yes, the first slide, but it's not presentation mode. Are you sharing the PowerPoint or just or the entire screen?
Oh, I think
it works better if you share the entire screen rather than a single window.
Okay.
Yeah, I was going to say it gives some control problems. So when you do the sharing, select and share, and when you share again, select desktop
screen.
Or screen.
So then we see what you see.
And then you go to the PowerPoint, and then we see what you see. Yeah. Exactly.
Okay.
Okay.
Great.
Very good.
Okay. So I might spend fewer seconds on these first 2 slides because I guess almost all in the audience well know why it is worth studying bone strength and trying to model bone strength. There's just one side, the fracture risk, the other being load. This graph is a classic, tells us that we need to improve the prediction of fragility fracture risk. And also, being in an orthopedic hospital, we need to answer questions like, should this lesion, be it osteomyelitic or metastatic, be operated, or may this bone withstand this implant? And also, we have a big question arising about how to treat and even understand the increasing prevalence of bone comorbidity in many chronic diseases which are of increasing prevalence in the population, also in genetic diseases, in rare diseases. And maybe to most of you, it is also obvious why it is worth studying bone strains, because they are relevant during the exercise. They are essential to keep our bones healthy. And not only they are restored by bed rest, but also by space flights, by presence of prosthesis, and also maybe troublesome after skeletal reconstructions. And we know that there are muscle-bone interactions. We do know that impact and strenuous exercise induce bone apposition. And also from a technical point of view, we know we need to study bone strains to understand bone strength. Okay, so maybe the biggest question in this presentation is why Marco asked me to do this. He knows almost everyone in the biomechanics community throughout the world, so he might well have offered an invited lecture to this guy from the US who is publishing a lot about clinical application of bone strength estimates, or maybe closer to us, to this guy here, which is possibly the one who is showing the most advanced models at the moment, and he'll talk about them later on. Or even to this guy here who spoke his brilliant presentation this morning about the synchrotron experiment with the femur. Or this guy here, younger guy that has done a lot for FE modeling and X validation. Or even this even younger guy here. But maybe the reason, because he asked me, is that together with these guys, we made quite a lot of work. I may recall some with Ben and Egon, this review that is still getting a lot of citations, and then with Max and Enrico, this work on CT calibration correction, and with Luca, a lot of work, also including Lorenzo in this sidefall modeling, and with Saulo, all the work on the prosthesis. So, okay, we need a bit of history here. My first contact with the Laboratorio di Tecnologia Medica was with Egon and Paolo at the bone mechanics season course in Udine, where John Carey, Steve Cohen, Rick Kaskis were presenting to us. And then there, I was already struggling with my just started PhD, and I remember that when two years later I found myself in some troubles with my PhD, and so in a snowy January day I went to Bologna and asked Dr. Vizziconti, may I salvage my PhD in this lab? And he said something like, okay, you're in trouble, we can offer you some problems. So in the April of the same year, I started working at LTM, and incidentally, I went to work with Fulvia, and at the beginning, it seems she wasn't that happy that I went there to work on the same thing she was working on, and we started to argue a bit scientifically, and in the end, we decided to make a family to get out of this, and it's been quite a successful, I must say. And so in 2006, in April, I finished my PhD doing something like the work of 3 years condensed in one. But the thing I do remember best from the April 2006 was the big party we organized for the 15 years of LTM. And now we are here for another good anniversary. Then, okay, it's another story. I kept on doing research at LTM, and then I contributed to build a Technopole lab, but went back to LTM to do research. And then the story of the last 5 years, maybe Fulvio will tell better than I can. Okay, so going back to bone strength, we know quite a lot from anatomy, physiology, experiments. We know that it's multi-scale, multi-phase, multi-physics. And we also know that to model it properly, we will need a better knowledge than what we currently have about all these parameters and the interaction that govern them across the dimensional scales. So we usually take a more clinically feasible approach. I use this slide from Mary Buxa in 2005. And okay, we can try to understand something about and model something about bone strength from FE models, and we build them from CT images because it's a good trade-off between feasibility and the information it can convey. And people have been trying doing models of bones from CT images for 30 years now. And in terms of the CT to FM workflow, this is quite established. I presented this slide in 2006 at the World Congress of Biomechanics in Munich, and more or less it's still valid. But we are still all discussing about how to model failure behavior at the continuum level and also at the structural level. We're struggling on loading modalities. Does a static or a dynamic loading better represent our situation? And while doing a model, should we just try to replicate a mechanical test or apply a more general loading scenario made of joint and muscle loading? And we're still arguing on another 1,000 details. So it comes naturally to discuss about how to assess finite element models of bones. And of course, the basic process goes through verification and validation. And if we think, however, about existing standards, well, on the regulatory aspects, even if I'm not the expert here, Marco may tell us much more about this. In the US, they already have quite established links between standards and the Food and Drug Administration. I know that also in Europe something is going on, but I don't know really well at which stage we are. And in terms of publication, I might say that despite the sample sizes are quite limited, the shared data are quite few, and also guidelines are rare. I can remember Clinical Biomechanics published something in 2005, but then it was followed by for some years, but almost abandoned then. And so the replication of models is quite challenging. And we recently adhered to an initiative launched by Serena Bonaretti, which I saw she was attending this conference, about the possibility to build some open and reproducible musculoskeletal models, including bone models. So this said, which is the situation about the modeling of bone strengths? There are not so many works addressing bone strength, maybe because it's quite a difficult and tedious work, and they've always been used with strain gauges, but now also digital image correlation and digital volume correlation is appearing, although some issues have still to be solved. I think these are very good experiments to challenge all the model variables we put in our models. And okay, when it comes to the results, they are very nice overall, I might say. And although there are some peak errors around, so one thing that comes natural is, okay, let's try to model bone strength. But before going to that detail, I'd like to recall that the applications that have already been published about the estimate of bone strains, and I need to say that Saulo Martelli, he has been a pioneer and is still doing beautiful work about this aspect, linking bone strains to exercise. But it was not only him in the community. And then, these are the main application, but we need to think also at some perspectives, because I mentioned earlier the presence of peak errors in validation. We, for example, try to see if they can be overcome by an explicit representation of the cortex, exploiting the cortical bone mapping published by Cambridge people some years ago, and we've found quite good results. And maybe some steps need still to be taken, possibly on cortical anisotropy. And also the modeling of the vertebral strains is much more challenging. And I think that as in the vertebrae, the inner trabecular compartment is at least as important as the cortical one. The digital volume correlation measurements should be one of the answers. So now shifting to bone strength, I would first like I would mainly speak about vertebrae and femur, because these are the most relevant applications in terms of fracture. And I might say that this is just a snapshot of a Zotero collection of papers about spine and validation, bone strength validation of the vertebrae. And there's a marked variability between experimental setup schemes and modeling workflows. And what I can say is that there is not the ideal experiment, because if we take a single body without the end plates, like Enrico Dallara did, it is highly reproducible and also showed to be better than DXA, but possibly limited. A single vertebral body with end plates and end caps, is still reproducible, but not so meaningful, because it does not represent trabecular and cortical sharing. And it's are potentially meaningful, but at present not sufficiently controlled, at least for the modeling side. So possibly improvements are still needed in experimental control, measurement technique, and trabecular cortical bone modeling. Going to the femur, the situation is quite different, because despite quite extreme modeling differences, there is many papers in the literature have shown a good accuracy of FE-based strength estimates, surely over BMD. And so, while on one hand, one might think of a sort of a seeding effect, so that we've just exploited all the information that CT can convey. The other thing that came to the mind of many researchers is that, is this enough to go clinical? Well, possibly at least to go beyond DEXA. And this is what around 10 works from 5 different groups have tried to do through the past 7-8 years. And I might say the most recent 5 have shown some improvements over DEXA with the AUC, let's say, sensitivity quantified by the receiver operating characteristic curve, shifting from the 0.7 of DXA towards 0.8. The improvement is not huge, and so possibly a good cost-benefit ratio can be achieved if we think of opportunistic screening, so using CT scans taken from other purposes to then model bone strength, or to apply this to high-risk subpopulations. And also here, of course, we we might think of other useful applications, not just predicting risk in a clinical cohort. For example, we can use bone strength estimates to try to understand bone strength determinants, and so to print sort of a fingerprint of a particular disease on bone strength. This is what we've been trying to do in a Klinefelter cohort. Or we might try to find a safety factor and maybe establish some trends against age or gender or bone mineral density measurements. And possibly next, this sort of paved the way to proper in silico trials. So these are the applications that can now be very effective through bone strength estimates. But looking to the future, okay, this the animation has gone bad here. I intended to talk first about the impact fall simulation, which is possibly one of the most interesting and fascinating works that have been published in the past few years. And this, for example, refers to the work of Ben Elgason. Ingmar Fleps is the first author in JBMR 2020 or 2019. Possibly I've mistaken the dates.
Sorry for interrupting you. You're running out of time.
Okay, I was. I'm concluding. Sorry for this, Luca. And I was just wanted to show the work that Lorenzo Grassi is doing, also to combine this dynamic experiment with the dose reduction building model from DXA. So then, in terms of future perspectives, if we want to really improve our models, we may think of exploring the non-mineral world. So going back to the experimental laboratories and possibly accessing the tissue level, and keep on working on vertebral bones and on how models are loaded. So thank you for your attention.
Thank you, Enrico. Sorry for putting pressure.
No. It was me running late.
Very nice overview. So we are moving far north. Lorenzo Grassi is the next speaker. Also, Lorenzo actually participated when we were doing the experiments, and he was very good at guessing the failure load. So his paper is predicting bone strength from DEXA images. Lorenzo, I already see your slides. Very good.
Excellent. Do you also hear me?
Yes, we do.
Great. So thank you, Luca, for the introduction. And I guess also thank you, Enrico, for the introduction, which sort of paved the way from what I'm going to tell right now. So I would start by showing my link to the laboratorio. So I guess that's why the reason I got invited to speak today. So I was working at the laboratorio from 2008 to 2011, sharing some very nice moments with some familiar faces, as you may see in these pictures. You can see Saulo's wedding and some other fun moments. And for good measure, I also shared my apartment with Matteo Balestra and Martino Pani during my 3 years in Bologna, so it made it for a short but intense experience. And during that time, I was also doing some work, and among those, with all the faces you see here, I have learned how to build subject-specific finite element models, starting from CT images, as Enrico gave a very nice overview of the topic just before me. So I was able to steal a lot of secrets about how to do this, and I will not go through in a very detailed way about the research question behind. Again, we know that the diagnosis for fracture risk is specific but not very sensitive, and so the hope is that using finite element models we can do better. And here you can already see a study from 1999, which is not probably the best study, showing that femoral strength is better predicted by finite element models than QCT or DEXA, but it's certainly the one with the best title. They got 340 citations, I guess, mostly thanks to this very nice and catchy title. But I guess here the keywords are the imaging type. So you can build this model from computed tomography, which is a 3D imaging type, as Enrico showed before. But DEXA, which is a 2D radiological image, is what is mostly used in the clinics to assess osteoporosis and fracture risk. So when I moved to Lund University in Sweden to get my PhD, the question became, can I build the same very nice finite element models that I learned to make in Bologna, but not using a computed tomography, but actually using one single two-dimensional DEXA scan? So that became sort of the main question behind that. So how do we do this reconstruction? The first step was to build a so-called statistical shape and appearance model, or SAM, as I would call it in a shorter way. So how do we build a SAM? We got 34 anatomies of proximal femurs, and we calculated the average shape, and we meshed that average shape. So that mesh was used as a template, and we then morphed all these template mesh to all the 34 proximal femur anatomies. And that essentially allows you to have 34 isotopological meshes, and then you can build a matrix that contains all the nodal coordinates and all the element-specific bone mineral density values for all this mesh. And if you run a singular value decomposition, the result is that you have created a SAM model. So you have the average shape and some principal modes of variation, and by a linear combination of them, you can reconstruct all your 34 femurs. In less mathematical and more practical terms, that's how it looks like. So a statistical shape model, you see how the shape changes from the average one to describe all the different modes of variation. And the statistical appearance model part, which is in this case coupled to the shape, you see how the bone mineral density distribution changes in the population as the shape also changes. So that's a pretty powerful and nice tool, but that doesn't really allow you to reconstruct the 3D shape out of the 2D shape. And as you know, reconstructing the 3D shape that creates a certain projection is a problem that has an infinite amount of solution. So here the SAM comes into play. So the way we decide to reconstruct the 3D shape is by selecting the SAM instance whose 2D projection best fits the target DEXA image that we have for that specific patient. So how do we do that? We first generate an instance of our SAM with the femur and the pelvis, and we create a digital reconstructed radiograph. These can then be compared to the reference image, and we define a cost function that includes the sum of the absolute differences for the two images, the digital reconstructed one and the reference one, together with the mesh quality. So we wanted to avoid excessive distortion in the elements, because in the end we want a 3D model that we can utilize. And we also control the anatomical position of some landmarks in order for the model not to go a bit, let's say, too much around in the space. And then we use a genetic optimization tool in MATLAB to run the optimization problem until convergence. And the final result is taken as the 3D shape for the specific DEXA image. So we went on to assess how accurate this reconstruction is, and we saw that when using clinical DEXA scan, so including the femur and the pelvis, we got an average reconstruction error of 1.4 millimeter. And the other interesting result was that we didn't see any major effect of using different DEXA devices in the reconstruction accuracy of the shape. And I guess the other good news was that the highest errors were located normally around the trochanter or most distally, so not in the region of major importance when it comes to predicting strains as stress in the proximal femur. And the same story we could tell also for the bone mineral density. Here the average error was 0.2 grams per cubic centimeter, which you can put into perspective by saying that the volumetric BMD can be over 1.2 grams per cubic centimeter for cortical bone. And here again, the lowest errors were in the femoral neck and the femoral head. So that was also very positive and promising. But still, we didn't know, is this really useful? Can we really use this to predict strength and strain? So back in 2017, 2016, we had this type of information available. So we had some mechanical tests in which we took cadaver femurs and we tested them in a configuration resembling single leg stents. And we measured the strength using digital image correlation. That was explained brilliantly this morning in its principles. We had our tool to reconstruct the 3D finite element model out of a 2D DEXA image. And we also had some CT-based finite element models, which are essentially a slight evolution of the techniques I have learned during my time at the Laboratorio di Tecnologia Medica. And so how to combine these three pieces together was pretty straightforward. So we want to introduce the finite element models as reconstructed from a DEXA image, so we call them sum-based, into this mix and see how they perform. So we created three different types of finite element models. One in which only the shape was reconstructed from the DEXA, but the bone mineral density was obtained from CT images. And one model in which the bone mineral density was reconstructed from the DEXA, but the shape was obtained from CT. And finally, the one in which both the shape and the bone mineral density are obtained from the reconstructed DEXA. So in these ways, we could check how the error propagates in this modeling pipeline. And we also wanted to test how this performs against three different types of DEXA images. One being the 2D projection of the available CT image, and then two real DEXA images obtained with Lunar iDEXA and Lunar Prodigy, where Lunar iDEXA is the newer device with a much lower pixel size. So what did we see from this study? Well, we saw that the reconstruction accuracy was better for the CT projection as compared to the DEXA images, and we didn't see any major difference in the reconstruction accuracy when using one DEXA device or the other, despite one being a lot newer and with a lower pixel size. So here the take-home message was that signal-to-noise ratio is the actual key and not the image resolution, or better said, the pixel size per se. And then we also saw that the femoral strength could be predicted with a slightly lower accuracy as compared to the CT-based finite element model, which could be, of course, expected, but still the maximum prediction error was around 13%, which you could judge to be still acceptable in a way. And another interesting finding was that if we look on the right-hand side of the table at the standard error of the estimate, you see that the error doesn't really propagate in the expected way. So we actually see that the finite element models, including either only the BMD or only the shape from the DEXA reconstruction, have a higher standard error of the estimate as compared to the models in which both the shape and the bone mineral density are reconstructed from the DEXAs. And that's probably due to the fact that our model includes shape and BMD in the same statistical shape model, so they change together. And there is possible some mechanism inside by which they sort of compensate for each other errors and actually give better results, which was comparable at least to the CT-based finite element models. So the second application was then to move all these assessments to a more clinically relevant case, which was the fall to the side. And to do that, we decided to join forces with the Ben Helgason's group in Zurich, where I was visiting last year. And it was a very fun and interesting time for me. I will try not to spoil too much about how these very cool models work, since I think Ben will talk about them in an upcoming presentation. But to make it short, we had 11 femurs, and we made simulated DEXA images using a tool called CTX80, which is an SDAI-approved tool to generate DEXA and DMD measurements out of a city.
No.
And we had available some mechanical tests running impact by Ingmar Fleps, and also some city-based FE models of the same impact, the one that Enrico was also mentioning at the end of his presentation. So we decided to make two different types of FE models. One that we call femur only, in which we only have the femur in a classic ex vivo side fold condition, and one in which you also have the biofidelic fold, where you have the two femurs, the pelvis, all the soft tissues, ligaments, and you simulate an impact by falling on the side at 3 meters per second. So then we wanted to see how does all this perform when we plug in our reconstructed femurs from DEXA. And what we could see is that now when looking at femur-only simulation, so you have the CT-based predicted peak force on the x-axis, and on the y-axis you have the peak force predicted by the models in which you run the DEXA-based reconstruction. So we got an R-square of 0.84 and a slope of 0.9. So we were reasonably happy with these results. But still, then the main question came, how will this perform into the huge biofidelic framework? And there the question is not only to predict the strength or the peak force, but actually to see whether a certain biofidelic fall would result in a fracture or not. So there, any small error could actually compromise the accuracy of this prediction. But what we saw is that we were able to predict the correct outcome in terms of fracture versus non-fracture for 10 out of 11 femurs. And for the 3 bones highlighted in yellow, we predicted the correct outcome, but with the wrong or non-accurate fracture location. And when we compare these to the city-derived finite element models, we can see that we perform very similarly. So they also predicted 10 out of 11 fractures versus non-fracture in the correct way, but they were a bit more accurate at predicting the fracture location. So we can build 3D finite element models from a 2D DEXA image with a good reconstruction accuracy and an acceptable loss in accuracy. Then the question is, can this be useful in a clinical scenario? Sure, it may. We would like to test lots of new things for that. We would like to train the SAM using more anatomies. We would like to assess the potential of these against clinical cohorts, and we are currently working on that. And it would be nice to include more information in these statistical models, so like the cortical thickness and improved material mapping, like those that Enrico mentioned before. And we could also see if more than fracture risk could be investigated. Do we have different research questions, or can we have the same research question but in different anatomies? So with all these questions, I will end my presentation, and if you have any questions, I will be at table 6 during the break. Thank you for the attention.
Thank you, Lorenzo. Very nice paper. I like the way you mix experiments and simulations. We then go to the next paper that Lorenzo already partially introduced. So we go to Fulvia today presenting massive biomechanics of massive skeletal reconstructions. Fulvia has been working for a long time in the lab. I don't think she needs any introduction. Everybody knows Fulvia already.
Thank you. Thank you. Thank you, Luca. So I try to share my screen.
Do the same magic that Enrico did.
Okay. Tell me I succeeded?
Yep. Very good.
Great. So good afternoon to all of you. I don't know who is present now. I'm still not fully comfortable with this kind of meeting, but it seems it's the only way to meet nowadays. So, but with respect to this morning, when I was really excited, I'm still excited, but there is a strange feeling because seeing all of these people together and talking with you, I mean, it seems to me that with some of you, we just met a couple of days ago, and this is not true. It's a strange memory joke. So I'm really happy to participate to this celebration of the 30th anniversary of the LTM laboratory. And when Marco circulated his presentation last week, I thought, well, 30 years, I mean, I was feeling much younger than that, actually. Well, just thinking again at it, I realized that no, actually not. I mean, I turned 50 this year, which is a terrific age. And my first fellowship in LTM started in 1999, so it's more than 22 years that I've been working in IOR. So this is an incredible amount of time. And I guess I'm one of the oldest here. So I also, when I arrived at LTM, I was a simple nuclear engineer, and actually I was born as a biomechanical and bioengineer in the lab, and I performed my PhD while I was working in the lab. And I wanted to take the opportunity of this anniversary and this meeting to publicly thank Marco, because I was born and I grew up both scientifically and professionally under his guidance. So I think I'm really, yes, I don't know if you can say emotion is more Italian, but I wanted to say thanks to Marco for that. But as he said, LTM was not just about work, was not just about research and science. Several friendships born in the period I worked there, and with some people I still see on a regular basis. And also I'm one of those that messed up things, as Marcus said, and I also derived my family from the experience of LTM. But as you might have seen and noticed, I don't have the affiliation of LTM any longer. Now I belong to the Bioengineering and Computing Lab. Very shortly, the story of this lab, it started at the end of 2009, beginning of 2010, under the guidance of Marco, and it was a framework of Emilia-Romagna regional project. So it had this hybrid identity, half a project, half a lab for many years. And in 2012, when Marco left the lab to go to Sheffield, I took the responsibility of the lab. The project actually ended in 2014, then 2 years of a limbo situation in which it was not clear what was the lab, what was going to happen to these labs. But from 2016 and up to now, actually, the new direction decided to give much more evidence and much more independence to this lab, and actually founded a department which is called the Research and Innovation Technology Department of the IOR, and the lab were moved to this department. So in 2018, the big lab was separated from LTM. And who we are, it's me, and Enrico Schileo and Giordano Valente, two senior researchers of the lab, Mauro Ansalone, the technician of the lab, and Gigi Crimi and Nicola Vanella, two programmers that follow us in the big. And now we have two new fellows. Our research topics are the same as before, so bone, finite element modeling, musculoskeletal modeling, and software development. Then Marco asked me to talk about massive skeletal reconstruction, and this is risky for me because, again, this is a topic I actually started with, and it was the topic of my PhD, so the risk of just going and digging into the memories was really present. While I would like to just give you the perspective I can do today on that clinical topic. So first of all, just to let you know, when we talk about massive skeletal reconstruction, we talk about bone tumors in IOR because we do not deal with trauma. And just because I do not want to dig into the past with memories, this is the first slide I've ever presented in my life at the first conference I went in 2002. And it is still actual. So, well, just to let you know now, survival is very good, and amputation is not an option anymore. So we are talking about restoring the function of the limbs that are operated and that go through disruption of the bone for tumor extraction, recover again the functionality. Still, since this is a rare disease, so the numbers are very low, there is no consensus about what is the optimal reconstruction technique. There are several reconstruction techniques. We are still discussing of what is the best in which situation. And the fact that we still, that this pathology affects young adults, adolescents, and children means that we have to deal with growing skeleton, and growing skeleton evolves and grows, and this reconstruction change dramatically during the follow-up. So the biomechanical implications are great, and even more if you think that this tumor principally affects the lower limb. So what we are doing today for this, to help this surgeon, we basically work on two different field. On one hand, we assist them in computer-assisted 3D planning of the reconstruction, and we perform biomechanical analysis. For what regards computer-assisted planning, we do planning both for biological reconstruction, in which the bones are reconstructed using massive bone allografts from cadavers, but also, more recently, we assisted the surgeon in the preoperative planning of pelvic reconstruction with the help of 3D printed custom implants. To do this planning, we leverage on the software that we have developed and we are still developing in the lab. So I take this opportunity to let you know that we are still having software development activity. We actually are still, we originated from the MAF, and I think the majority of the older people here know what the multi-path application framework was. When the MAF was discontinued, we and Mark agreed that the MAF logo could not be used anymore, so we gave birth to the Agile Library for Biomedical Application called ALBA, which is a nice name for an Italian. That is actually the evolution of the MAF that is still being developed and maintained. It's alive, and Gigi Crimi is the responsible for this software development. So this is just a news for all of you that knew MAF in the past. But we actually perform also biomechanical analysis to investigate and help the surgeon in the reconstruction, in massive skeletal reconstruction. At the beginning of this research activity, I thought, at the beginning, many years ago, I thought that we could use biomechanical models to give input to the clinician to optimize the managing of the rehabilitation. Well, now I think that this is not feasible really, because the effort in times and manpower needed to build such models is really too big to be compatible with the clinical decision times needed for managing this reconstruction. But I still think that our biomechanical analysis are useful to optimize the reconstruction technique and can contribute to the understanding of the biomechanics of different surgical techniques, so comparing different surgical techniques, and also, quite recently, also in the validation of new prosthetic design. We use the workflow that has been shown also before by Enrico, so we use workflow to go from 3D data to finite element modeling. We use our classical workflow to develop musculoskeletal modelings from medical imaging to predict forces, joint forces, and muscle forces during different motor activities. What I want to show you now is just the latest project we are involved with, and it's analysis of pelvic reconstruction with custom implants. It is an internal project, so it's all internal to IOR, but it involves different units of the institution. And actually, the rationale of this project was that since custom implants, 3D printed custom implants became available, and let the possibility of having big defects reconstructed with trabecular material, then our surgeons started to adopt this solution massively for reconstruction of big defects in the pelvic bone. This is because the classic reconstruction technique actually left major impairment, it was really difficult to obtain good functional recovery. But of course, since the short-term results of this reconstruction are very good, the surgeons are using it more and more. But there is no long-term follow-up after now, because it's quite a recent introduction into the market, and they still don't know. So there is no preclinical validation of these implants, as they are completely custom. So we thought that it was necessary to give an insight on the biomechanics condition these implants work during daily activities, and also the biomechanical condition the host bone live during daily activities. So we enrolled a clinical cohort of patients that actually might seem very small because it's just 6 subjects, but if you think of the pathology, it's one of the biggest available. And for those subjects, we perform quite large data acquisition. We performed gait analysis in different motor tasks, and for each motor task we had different various repetition. And so we could investigate the joint contact forces and the most influential muscle forces during these activities to understand the difference between the operated and the contralateral limb. So we obtained data both on variability between subject and intra-subject, and we actually confirmed what was the impression, that the functional recovery was very good in the short term, because we found differences between the operated and the contralateral limb, but specifically in those most demanding tests, while these differences were quite low in walking or other less demanding tests. But the next step would be, of course, to investigate if this mechanical working condition are leading to possible bone resorption in the host bone, or exposing the custom implant to any particular critical situation. So this will be the work for the future. Well, I'm aware that this application of our methods is not possibly the one that gave us the best scientific results. These studies are quite difficult to publish, actually. But I really like this application, and I really like this part of the work. I wanted to show you a movie here, but I did not manage to have it work on the Mac, unfortunately. And in this movie, you could see this little girl, and this little girl was operated when she was 17 months old. And it was the reconstruction I show you, just the first plan in the reconstruction I showed you before. And it was the youngest person in the world that has ever received a hip prosthesis. And when she received this hip prosthesis, she was not able to walk, so she learned to walk with a prosthesis on, and this was the first time in orthopedics worldwide. But apart from that, it was a girl. At the time she was operated, she was exactly the same age as mine, and being able to help the surgeon in planning this intervention and seeing that the result was so good actually rewarded me a lot on a personal perspective, not on a scientific one. But I think that this is one very important part of our work, being engineers devoted to translational research towards the clinical practice, and to be able to see the application to really help the people. So that is, and I thank you for your attention.
Thank you, Fulvia. Very exciting application, especially this last one is very touching. We can go now to the fourth presentation of this session. Benedict Helgeson is an old friend from Iceland. He came to Italy. I've tried to retrieve from the old contacts. I think it was around 15 years ago. We thought he was in Italy only for fishing and to explain the art of smoking salmon, but then we found out he was also very good at doing finite element modeling. So the paper that Ben is presenting is about predicting bones at impact.
Do you see my slides, Luca?
Yes.
And do you hear my voice properly?
Yes, we do. Yep.
Well, anyway, happy anniversary, Marco and everybody. And thank you for the introduction, Luca. Yes, the title of my talk is Predicting Bone Strength at Impact. And like Lorenzo, I do not plan on spending a lot of time justifying why we do research into hip fractures in the elderly population, but I will, as a primer to the slides that will follow, mention that there is ample evidence out there showing that the majority of these fractures is actually associated with a low trauma fall. And Lorenzo also mentioned the current clinical standard for assessing hip fracture risk, that is to use two-dimensional DEXA images, and from these images derive aerial bone mineral density, which has been demonstrated to be moderately accurate in terms of finding at-risk individuals. But this idea of working with femoral strength and using CT data and construct from CT data three-dimensional finite element models of the proximal femur has been around for maybe 30 years. And I think this graph here on the right side sort of demonstrates nicely what the field is trying to capture with this idea. Here you see plotted on the horizontal axis the aerial bone mineral density for about 600 subjects in the ages Reykjavik cohort data, and on the vertical axis you see predicted femoral strength. And at any given aerial bone mineral density, you will find two individuals that may have up to 100% difference in their predicted femoral strength. It's been super interesting to monitor the development of modeling technology for this injury or application in the field, and also to be a part of it. And it starts with for what I'm concerned at LTM in this period here, 2003 to 2008, where I was a PhD student at the University of Iceland, and I spent probably in this period accumulated 12 months in the lab. And as a primer to the next three slides, I will say, and Enrico mentioned this a little bit, that the groups in the field that are modeling the proximal femur are using very similar techniques. It starts with a segmentation step, and this has been quite time-consuming through the years. And then there's an automated meshing step. But the thing that we were working on together in Bologna was this step here, the material mapping, which is all about how do you translate the gray level intensities in the image data to meaningful mechanical properties for the finite elements in your finite element mesh. And Fulvia, Enrico, and I, in this period, we tested three different methods for the material mapping, and we were getting better and better correlations between Lucas measured strains and our predicted strains, but we always had this sort of a systematic underestimation in whole bone stiffness by the finite element models. And this sort of brought our attention to this review that Enrico mentioned, or the topic of the review, which was modulus density relationships. And they are sort of telling us at what a given bone density represents in terms of stiffness. And it turned out that Egon had actually collected something like 200 or 300 papers on the topic in his PhD work, and we reviewed this together and found that these relationships published in the literature were sort of all over the place. That sort of brought us back to looking at which of these relationships should we probably be using for our modeling. And I tested this relationship in my thesis, and Enrico did that in this paper here as a part of his thesis, and we found that it would give us a close to one-to-one response in between measurements and predicted response, which was nice. And I'm not going to hesitate to state that I think we, in this period, we made a significant contribution to the field by providing, I think, sort of better understanding of what it actually takes to build accurate models to model these injuries. And maybe the field is acknowledging that by citing these papers that I just mentioned more than 1,000 times. But we should also acknowledge that there were other groups in this period that were also producing excellent validation outcomes with sort of similar methods. So my feeling is that the field was reaching a sort of a joint conclusion on this a little bit, and we see this in the period that follows, that you see these excellent validation studies being published, and Enrico mentioned some of them, and here's a study from Lorenzo as well, where there's an excellent match when you're validating these models against ex vivo cadaveric testing data. But at the same time, there are groups in the US that have started to validate their modeling technology against clinical cohorts. So they had access to large databases of CT data for elderly individuals for which fracture history was known. And what they're concluding from their work is that they find these models to be no better at finding at-risk individuals than just using a BMP. And this was a little bit sort of disappointing in the field, and I think different groups went into different directions. So what we decided to do is to try to focus on the impact aspect of this problem. So I'm talking about this period here where we sort of introduced this concept of explicit finite element model simulating impact. And we published 4 papers in this period on this topic. And I do admit that we were struggling a little bit at the time to find a good match between our simulation results and the experimental results. We were dropping a relatively large mass onto the proximal femur. One of the things we were, hadn't completely under control at the time was the boundary conditions that we actually had in the experiment and how to model these properly and with the finite element models. But in 2018, a PhD student in our lab, William N. Bray, came up with this material mapping strategy where he introduced strain rate dependency in the bone tissue response, introduces complex nonlinear behavior even after maximum stresses were reached, some softening effect, and so on and so on. Quite complex. And what he finally got out of this was a sort of a moderate correlation, albeit lower than in previous quasi-static literature, but he could sort of fully explain that by the fact that his measurement range was only half of what previous studies in the quasi-static literature were reporting, because he had predominantly female donor specimens in his test data. And you could see it in his root mean square errors that was sort of comparable to some of the better studies out there in the quasi-static literature. But we wanted to move on from this, focusing on the femur only. So we wanted to add some biofidelity to our impact simulation. And this is this period here where we are introducing these types of modeling techniques. And this is the work of Ingmar Flaps that has already been mentioned a couple of times in previous talks. These 4 papers here is basically what he put into his PhD thesis, but he was working on this probably from 2016 and so on. He wanted to go back and look at the events that sort of caused these injuries, like the one here, and do a better simulation of the event itself. So he built this fall simulator, and into the fall simulation he embedded human donor pelvises and femurs into surrogate soft tissue, which was sort of donor specific. He modeled or built a lower limb construction. he guides the fall of the specimen onto a force plate where he can measure force time response. And it looks something like this, but Ingmar is also a wizard of computational modeling, and he built these sort of models where he models almost every screw and bolt in the setup, and you see a qualitative comparison of the experiment and the simulations here. But his validation outcome was, in terms of force time response, was just really, really good. He was matching this for almost every specimen, but also he also qualitatively compared the predicted strain response that he got from his finite element models to the fracture patterns that he observed after dissecting the specimens in the anatomy lab post-fracture. And he actually got a very good match in this case, as well as Lorenzo mentioned in his talk. A very interesting byproduct of Ingmar's simulation work was the fact that he could actually quantify where the impact energy is absorbed in individuals that do not fracture as a result of a fall. And this has been a little bit of a mystery in the field, because it's a well-known fact that the femurs alone can only absorb maybe 5 to 10% of the impact energy. And he's finding out that, at least according to the simulation, on average, more than 50% of the input energy is still in the form of kinetic energy at the time of peak impact force. And this is due to the fact that the soft tissue is still carrying speed at the time of peak impact force, and the whole specimen or setup is rotating at the time of peak impact force. But this has never been quantified, and is an important information to the discussion in the field of where the energy is absorbed. Well, we actually managed to move this technology, simulation technology, into a clinical cohort with the study by William and Spray in 2019. William worked on this for quite some time, and what he managed to come up with was a pipeline that allowed him to construct these relatively complex models in 20 to 50 minutes, including the segmentation part per model, which was quite impressive. And he modeled 254 women in the Aegis Reykjavik study cohort using the baseline CT data as input. And all these models he subjected to an impact simulation with an impact speed of 3 meters per second. He derived some finite element result parameters and calculated an AUC as a metric that quantifies accuracy in classification. And what he found was that his AUC was slightly higher than the AUC derived for area of bone mineral density for these subjects, but this difference was not significant, disappointingly. But then he did an analysis on a subgroup of what we call the likely fallers in the group, and in this case, he's finding quite a significant difference between his finite element results derived AUC and AUC for area of bone mineral density. But here it has to be said that we are using post-fracture information to define the likely fallers group, and that is a relatively poor simulation of the problem that the clinical practice is facing at baseline, where they only have baseline information to assess the risk of future fracture. I guess this suggests that we should be focusing on finding the fallers in future studies, and that is something that we're working on in our group. So, I want to end this just with a few slides on what you should be expecting coming from our lab in 2020 or beyond, rather, I would say. And it's a funny coincidence that while Marco was presenting this morning, I got some news from our people here in Reykjavik that are working on the Aegis Reykjavik study cohort that we're getting interesting results that I plan to tell you about on next slide. I can see, but first I would like to mention this study that Ingmar has just finished. He went back to the Aegis cohort and modeled 600 of the subjects and built femur-only models, And then he tested the material mapping strategy that William and Spray published in 2018 with the strain rate dependency and complex nonlinear properties. And then he tested reduced strategies as well. He switches off the strain rate dependency and then switches off the strain rate dependency and nonlinearity to simulate simply linear elastic response. And he is actually finding here significantly higher AUC from his finite element results or femoral strength than area bone mineral density for the two most complex material mapping strategies. And he's only using baseline information, so the baseline image data. And this was why this is the case, why he is maybe the first one to get this difference using baseline information only. I don't know. Previous studies, as I mentioned, did not find this to be the case, but there is some difference in the modeling technology. The groups in the US using voxel level models, but we are using these more smooth models, which is the LTM school basically. And yes, this is what I wanted to mention to you, that I received an email this morning that we've actually managed with an automatic segmentation method and an automatic pipeline to build our finite element models based on the HS-RayCAG study data. We've actually segmented the whole cohort now of 4,800 data set, that is 9,600 bones. And we developed this method with a group of researchers at the University of Iceland. And we have we had manually segmented 600 bones from Ingmar's study and compared the strength with manual segmentation and automatic segmentation, and found the match to be or difference to be relatively small. So we will be submitting this paper, I think, in the next couple of weeks, as well as Ingmar's paper that I just mentioned. This is my last slide, I think. So what should you expect from our lab in summary in the next year or two? As I said, we've actually now built 9,600 proximal femur models from the HS-RayCAG study cohort, finished during the weekend. As said, it will take us a few months to run that through our cluster facilities. So femoral strength we will know for all these subjects, or predict it sometime during the spring. You should also expect sometime, I would say soonish, that we will do a study on the biofidelic models. We have automated that pipeline as well, or just finishing that automation. You should expect to see a study with a large number of these models being modeled and analyzed maybe in 2021. And you should also expect from us results from in silico clinical trials on preventive treatment strategies such as femoral augmentation with cements or implants, or studying the biomechanical efficacy of head protectors. That's a small add-on to these models. Once you've built all this, adding the pad, for example, is not a big deal. So you should expect that as well. I think this is my last message. I acknowledge my collaborators and funding sources, and happy to take questions. Break if you have any. Thank you.
Wow, even just the number is impressive. 9,600, and not to mention the methods. Very, very, very cool. Thank you, Ben.